Good afternoon. I'm Dr. Sushruta Mokadam from Motherhood Hospital, Kharadi. Welcome to this webinar. And today we will be discussing pregnancy-related drugs, medications, and their side effects. So rather than the side effects of the drugs per se, what I want to tell you is whether these drugs are safe in pregnancy, the safety profile of all the drugs that we are giving in pregnancy. Because when we come to a doctor, there are certain drugs which are pregnancy related prenatal vitamins which are considered safe, but there are other drugs that we give to treat symptoms and diseases during pregnancy, and the safety profile of all these drugs is very important for the doctor to know so that she or he can prescribe you the right drugs in the right amounts. And most of the patients today are very informed, and they ask us, is this safe? So every time we prescribe a new medication, they ask us what it is for and whether it is safe, whether it will have any effect on the baby or their own health. And while it is you can take for granted that your gynecologist knows about the side effects and the safety of the drugs, it is always good to just make sure. And there is no harm in asking the gynecologist. In fact, sometimes we brush up our own knowledge to double check when the patient asks us any questions, because nobody is infallible. There may be some lacunae in our own information also. All right, so let us go to what happens in pregnancy. There are factors affecting the drug pharmacology in pregnancy. What is drug pharmacology? Whenever you take a tablet inside, whatever it may be, it is digested in the stomach, and then it goes to the liver, it goes to the blood and to the liver. And the liver metabolizes that particular tablet into its active metabolite or the active ingredient, which is supposed to then go back into the blood circulation and then go to the target organ and give the symptomatic relief or do its job. Now, what happens is there is something called a liver first pass metabolism, and how much drug is delivered to the target organ depends on the dose that has been taken, how many times a day, and other variables such as this. Now, what happens in pregnancy is that the gastric pH is increased. So the amount of drug that is digested or released in the stomach, that may have a role to play in that. The gastric emptying time is decreased. What do you mean by that? That means in pregnancy, since there is, under the effect of progesterone, the basic gastrointestinal system, the smooth muscles of the gastrointestinal system, they relax, and that can cause things like relaxation of the lower esophageal sphincter, causing heartburn and acid reflux. Food remains in the stomach for a longer time, that can cause a feeling of bloating, and then food is not pushed in the intestines as before, and therefore that can lead to water absorption and constipation. Now, these are some of the symptoms that are seen in early pregnancy and sometimes throughout pregnancy. But what happens is, because of gastric emptying being delayed, the amount of time that the drug or the tablet remains in the stomach also increases. So that's why we need to know how much of the drug is actually absorbed. The maternal blood volume increases. That means that the pregnant woman's blood volume, which was 5 liters in a non-pregnant state, becomes almost 5.5 liters. So this increased dilution means that when any drug comes into the bloodstream, it is diluted in more fluid. So the amount that actually is delivered to the baby or to the mother's organs is lesser than in a non-pregnant state. Kidney filtration rate is increased in pregnancy, which will mean that certain the water is flushed out of the kidneys faster, and certain drug metabolites are excreted earlier. So the time that the drug is inside the body, that becomes less. And of course, effects of hormone on liver metabolism, that can lead to how the drug is actually converted into its active metabolite. What are the interactions with the other drugs and other food items that also go into the liver. So there is a competitive inhibition at the level of the liver between all the nutrients as well as the drugs that are given. So when we're talking about drugs, medicines going to the baby, why how does it go? It goes through the placenta. What is the placenta? Placenta is the organ of exchange of nutrients. So everything to the baby, that is the organ which is supplying everything from the mother to the baby and allowing the baby to grow. All right, so the exchange of nutrients through the blood supply through the placenta and the umbilical cord to the baby goes on throughout pregnancy till delivery. So once the baby is out and delivered and then we cut the umbilical cord, that is when the relationship between the mother and the baby stops, and then the placenta is delivered after the delivery of the baby. What happens is now the placental bed circulation allows most drugs to cross over from the mother to the baby. There are certain big proteins that do not cross, but the larger molecules do not cross, but the smaller molecules, which are most of the drugs are smaller molecules, they are known to cross the placenta. Therefore, whenever the level of any drug increases in the mother's blood, then it subsequently goes to the placenta and may go over to the baby. And therefore, we are very concerned about what tablets, what drugs the mother is consuming throughout pregnancy, and the amount of that particular drug that goes to the baby and the effect that it has on the baby inside the baby's body. So that is very important. And what we are most concerned about is that some medicines or some drugs have a potential teratogenic effect on the baby. What is teratogenicity? It is the formation of abnormalities, structural defects, what we call birth defects. So we do not want any birth defects to happen in the baby, and therefore, especially in the first trimester, which is the first 3 months of pregnancy, up to 12 weeks, 2 weeks from the time that the patient has conceived, that is the time that the missed period happens, to about 12 weeks of pregnancy, we are very worried about whether the patient has consumed anything which will lead to birth defects. And the birth defects are seen, some of them as late as 18 to 20 weeks in the anomaly scan. And only then we can find out whether the baby has any birth defects. Though some birth defects are seen, very obvious birth defects are seen at the 12 weeks nuchal translucency scan also. But what we want to know is that the period of organogenesis, that is when the baby is actually being formed and the baby's organs are formed and the baby differentiates from a mass of tissue into a structurally competent fetus, like from the embryo to the fetal stage, which happens around the 8th to 10th week of pregnancy. That is a very crucial stage where any kind of insult in the form of, say, any drug that is taken or high blood sugar levels in diabetics, this can lead to abnormalities, structural abnormalities when the baby's organs are being made. So caution should be exercised. And therefore, in the first trimester, we are very cautious and we have a very, high level of awareness or alertness about what we are prescribing. But the effect of the drug, any drug, is dose specific. So it's not like if you've eaten 1 tablet or even 5-6 tablets that there will 100% be the same effect as when you've been consuming something throughout, like say for a month. So it is important to know that certain drugs, if taken over a long period of time, they can cause teratogenicity, and then that is the time when we advise an abortion. So whenever a patient comes to us saying we have had this problem and is it safe to continue the pregnancy? So for the gynecologist, that particular question is very important. Is this pregnancy to be continued or should we advise an abortion? And before 12 weeks, people want to have that choice of abortion. So that is why we have to now see whether this particular drug which has already been taken, will it have an effect on the baby, and whether any further treatment that is required for this particular patient should be shift over to a more fetus-friendly drug rather than a drug which can cause later damage to the fetus. So the risk-benefit ratio is always to be done. Now, FDA, which is the Food and Drug Administration, has categorized drugs in pregnancy, and they are A, B, C, D, and X. Now, every drug that you will see, the reason why I'm telling you this is whenever you read the literature, pharmacology literature that comes with the drug, there will always be contraindication specific interactions, and they will say that not to be used in pregnancy or used with caution in pregnancy, and the category of the drug will be given. It's a category C drug or a category D drug, not proven safe. Now what happens is, if every drug you take, there will always be used a footnote saying use with caution in pregnancy and lactation. However, gynecologists do prescribe these drugs. So that is because newer and newer studies have been done, and it's an ongoing study. Any drug that is used in modern medicine, what we call allopathy, undergoes several studies. They undergo animal studies in lab animals, and then they undergo even human trials. And only after these trials say that it is safe, that is the only time that this drug comes out in the market with the attendant warnings. So when we see pregnancy categories and drugs which are safe in pregnancy, so there is category A drug, and the safety has been proved. There have been human trials, and there has been no risk. Now, what constitutes all these things? All the prenatal vitamins, all your iron, calcium, folic acid, B12, all the vitamins, omega-3 fatty acids, probiotics. All these are safe. They have been extensively tried in human and pregnant women, and found that there was no risk to the mother or the baby. And even levothyroxine, which is your thyronorm or L-toxin, that is the thyroxine hormone. That molecule is very safe in pregnancy. In fact, it is life-saving for the mother and the baby. Now, these drugs which we always give, they have absolutely, there is no risk to the mother or the baby. So there is no harm in consuming it. In fact, it is a vital ingredient of your pregnancy plan. Now, what is category B? Now, these are the drugs which have not been tried in human trials, but they're generally considered safe in animal studies. And in pregnant animals, they have not been shown to be teratogenic in the lab animals, and therefore they can be used. So there are certain drugs which are category B, and we can offer them blindly to a pregnant woman without any risks to the mother or the child. Now, in C category, it is not safe in animal studies. In certain animal studies, they have been found that there is some problem and risk to the pregnancy. But because these drugs are important for the health of the mother, or they have to be prescribed to the mother for her condition, then sometimes we have to give a little bit of leeway in prescribing such drugs, keeping aside the fetal position, and allowing the mother to have a benefit of this. But the risk benefit ratio in category C drugs has to be maintained, and the patient, it has to be given in as low a dose as possible and for the shortest time possible, just to tide over that particular crisis. Okay. And in category D, there are actual proved risks to the fetus, but benefits to the mother are life-saving. Now, if the mother is having a life-threatening disease or an infection, and certain drug has to be used to save her life, then we are not going to tell that, and there's no other cheaper, safer alternative to that particular drug. Then sometimes we have to give the patient the choice of using this drug to save her life. But yes, there are certain risks to the fetus which can be explained. All right. And category X are the actual teratogenic drugs. These are the drugs which, if you come saying, I have had this drug, then I advise, we never prescribe it during a pregnancy for any reason. And if there has been exposure to this drug in the first trimester, during the period up to 12 weeks, then we actually advise an abortion, because the risks to the baby and the pregnancy being harmed is very high. Now, what happens is, there are several reasons why there may be birth defects in the baby, and the general percentage of birth defects in the population, even without any drug exposure, is about 3%. And the general population abortion rate is 15%. without any other confounding factor. So that is how all these drugs are, risk stratification is done. Is this risk more than 3% for birth defects, or is it the same thing as it is in the general population? Then these drugs cannot be considered the cause of that particular birth defect if it is anyway less than 3%. And same thing for abortions. If the general population is going to have a 15% abortion rate, then whether this drug should be considered unsafe because its rate is the same as 15%, then we don't really consider that this abortion was because of this particular drug. And that is how studies are done and things. Let us talk about simple drugs which are given in pregnancy and why we use those particular drugs for all the common diseases in pregnancy. Let us take a look at antibiotics. So when do we use antibiotics in pregnancy? We can use it for upper respiratory infections, sometimes lower respiratory infections. Now COVID came as a lower respiratory infection, and that has actually changed our perception of disease in the current scenario. And many pregnant women were COVID positive, and they were given some kind of antibiotic prophylaxis to guard them against a lower respiratory infection and lung involvement. So antibiotics were given for the respiratory infections. Urinary tract infections which happen in pregnancy should be treated, because not treating urinary infections can lead to actually growth retardation in the baby. So and even kidney infections when there is an ascending urinary tract infection. So these are then of course there are gastrointestinal infections like loose motions, diarrhea, dysentery. These need some other doses. Vaginal infections in pregnancy need active management, because vaginitis or vaginal infection can lead to cervical softening, cervical shortening, and premature labor, even premature rupture of membranes. So these are the things which can cause premature birth or even an abortion. So that is the reason why we always check. So which are the category B drugs? That are now, most of these drugs that we prescribe are category B, that is the animal studies have not shown any risks. So nitrofurantoin is a very common Nifty or nitrofor. It's a very common urinary tract antibiotic, as also fosfomycin, which is the latest trend. It is a single dose fosfomycin sachet is given with water, and fosfomycin is also category B. Okay, what we give Monirol or Fosirol, Novofos. And it is ease of administration that has made it popular. Any kind of amoxicillin, ampicillin, and cephalosporins, as well as azithromycin, they are also category B drugs, and they are safe in the second and third trimester. Mostly we try to avoid all these drugs in the first trimester because they are category B drugs and no human trials have been done in pregnant women. But the common side effects are nausea, vomiting, diarrhea, hyperacidity. So this may be co-prescribed with antacid or a probiotic in order to make sure that these drugs are well tolerated. And anyway, any course of antibiotic does not go beyond 5 to 7 days, so these are safe. Even drugs like Metrogyl or Satrogel, which are for the gastrointestinal tract, they are considered safe in pregnancy and are given. Secnidazole is given for bacterial vaginosis. Ciprofloxacin and sulfa are category C drugs, and they are not generally recommended. And the actual category D drugs, such as tetracyclines or doxycycline, amikacin, gentamicin, they are contraindicated. We try to avoid them as far as possible. All right. So these are the drugs which we say don't take it. There is another drug which is vitamin A, that is tretinoin. Many people take treatment, skin treatment for acne, and then they come up with a pregnancy. Now, if tretinoin has been used, then we actually advise an abortion, because retinoic acid is teratogenic. It can cause birth defects. The other drug, which is not an antibiotic but very common prescribed is the abortion pill, that is misoprostol. Now, whenever a patient comes for an abortion, early trimester abortion, less than 7 weeks, and the medical abortion option is given to her, and then she consumes those medical abortion pills, it is expected that the pregnancy terminates. But in some rare cases, when the pregnancy does not terminate and goes ahead, and then it is found later after 2 weeks that the pregnancy is actually growing, now this misoprostol tablets which have been given do have an effect on the structural growth plate of the baby and will cause defects, and therefore we will then advise a surgical termination of this pregnancy. So it is not advisable to continue a pregnancy which was earlier scheduled for an abortion, but for some reason it went ahead. We have to terminate this pregnancy in some other form. We do not generally ask the patient to, okay, if you want, you change your mind. So there is no changing of the mind. If you think that you're going to change your mind after consuming those pills, it is best that you take a few days to reconsider the decision before taking the tablets. Very commonly, cough and cold medications are prescribed, that is antihistaminics and cough syrups and everything. Now, these are quite all right, but then we give them in the second and third trimester, these are quite safe. First trimester, they have their own, every formulation has different chemical composition. So we have to then, see the safest one, which has got the least possible side effects in the first trimester. We can even opt for herbal preparations which do not contain any chemicals or drugs. Cetirizine, Allegra also, they are all category B drugs. And asthma inhalational steroids could be category B, C, or D in the first trimester. So all these things which are already patient is on, where once she is pregnant, if she is on an inhaler or a steroid inhaler, then we have to give her the option of some other safer medicine in the first trimester, so that she does not have, because steroids do have some kind of an effect on the birth, may cause birth defects. Which is the safest drug in pregnancy? Paracetamol is the safest drug in pregnancy for fever or any kind of pain in pregnancy. So paracetamol is also called acetaminophen, and it is safe in pregnancy. Therefore, for any pain, any headache, any musculoskeletal pain, backache, it is always advised to take either a topical pain analgesic like Move, or you can use paracetamol in the form of either 500 milligrams or 650 milligrams. So it's always Crocin or Dolo that is given, and not Combiflam. So what happens with things like Combiflam, ibuprofen, naproxen? Now these drugs, even though their safety is not being documented in the first, second trimester, what happens to these drugs in the third trimester when the baby is fully formed and closer to term and closer to delivery, is that it can cause a premature closure of what is called a ductus arteriosus. And the ductus arteriosus is a blood vessel which is present in the fetal circulation, which is a conduit between the baby's aorta and pulmonary vessels, because inside the womb, the baby's lungs are not functioning. They are waterlogged. So the baby's lungs are in a dormant stage. They're still in a growing stage, and they're not actually mature enough to handle the thing. And anyway, the baby's floating in water, so there is no air exchange. So where does the baby get its oxygen? It gets oxygen from the placental blood, mother's blood, which is oxygen enriched, goes to the baby. And then this ductus arteriosus is the conduit from where the baby's heart and the rest of the body derive the blood supply from the umbilical vessels. So what will happen if this ductus, now after the baby is born, after 3 days, within 3 days of birth, this ductus naturally closes. This blood vessel closes because now the baby's lungs have taken over, and then the baby gets its own oxygen supply from the atmosphere, and then there is oxygen and air exchange in the baby's lungs. So that ductus naturally closes within 3 days of birth once the lungs have taken over that job. What will happen if this ductus prematurely closes while the baby is still in the body is the baby can have a heart failure, baby can even have very difficult side effects. There can be some other problems. So The usual OTC drugs like Combiflam are not recommended in pregnancy for any pain also. So we have to be very careful while prescribing the painkillers in pregnancy. Just remember that we have if there is any doubt in your mind as to whether a particular drug can be used in pregnancy, even sometimes you need painkillers during any dental treatment that happens during pregnancy or toothache, always go for the safer option of paracetamol and not the other NSAIDs, that is non-steroidal anti-inflammatory drugs like Combiflam. Even in diabetes, now there are some people who are already diabetic and then they get pregnant and they are taking oral anti-diabetic drugs, what we say OHA, oral hypoglycemic drugs. So agents. Now, metformin is a category B drug, which is safe. So glycomet, yes, we are giving to our PCOD patients and then they get pregnant. They can continue taking metformin. In fact, the first drug of choice nowadays in gestational diabetes mellitus is also metformin prescribed by the gynac or the endocrinologist. So metformin is considered safe. Even myoinositol is considered safe. But in the other drugs, the sulfonylureas or other drugs, they are not considered safe in pregnancy. You have to shift over. So the moment a diabetic patient gets pregnant, she has to go to her endocrinologist and says, now I'm pregnant, I need a shift to sometimes even insulin. So insulin is considered safe. There are different types of insulins, and the human insulin, or there are certain drugs which are insulins which are safe in pregnancy. So the endocrinologist will shift you over to that. Sitagliptin is not studied, but it is safe. But however, we try not to give it in pregnancy because there have not been enough studies to show the safety. So anyway, we have two very important things in pregnancy to control blood sugars, that is metformin and insulin. And with these two, it is very easy to actually manage the pregnancy diabetes. So hypertensives, I have not mentioned antihypertensives, but even those who are chronic hypertensives, especially nowadays when we are seeing patients above the age of 35 getting pregnant, who have already contracted hypertension or diabetes in the course. Now, these people are already on a chronic medication. We need to see whether these medications are safe in pregnancy. So the moment you get pregnant, please take your prescription to the gynaec and to your other physician and see whether these drugs can be continued in pregnancy or we shift over. So in pregnancy, we are not allowing any other antihypertensive than labetalol. We are not even allowing atenolol. So you have to shift over to a pregnancy-friendly or pregnancy-safe antihypertensive also. Ecosprin is that is a very low dose aspirin in the doses of 75 and 150 are anywhere prescribed in pregnancy for their antiplatelet action. So they are, if they are carrying on before, you can carry on later on also. Talk about immunizations. Whatever immunization or vaccines we are giving in pregnancy, they are inactivated form of vaccines. We are not giving any live vaccines in pregnancy. They are contraindicated. So tetanus toxoid, tetanus diphtheria, that is TDVAC, or Tdap or Boostrix, that is tetanus, diphtheria and acellular pertussis. Then the seasonal influenza vaccines. These are all the vaccines which are given in the second and third trimesters. We avoid giving any vaccines in the first trimester. And nasal influenza vaccine is not given in the any trimester of pregnancy because it is a live vaccine. Considering even hepatitis B vaccines, most people are usually hepatitis B they have been vaccinated before. So what we generally see is that when it comes to vaccines which are adult vaccines like rubella, like hepatitis B, ideally these courses should be finished before pregnancy. Even the HPV vaccine, that is Gardasil, the cervical cancer vaccine. Now, all these courses should be ideally finished before pregnancy, but if it is taken accidentally, then there is no reason to terminate the pregnancy if it is a inactivated vaccine. And then maybe the next dose will be deferred after the delivery, but that is all right. But we don't give any live vaccines. Currently, COVID vaccine, because it is not a live vaccine, it is an inactivated vaccine. It is given for lactating mothers. The government of India has approved it for lactating mothers, and hence we have started actively vaccinating delivered patients. Still, the pregnant patients have not been given the option of taking this vaccine, even though in certain countries abroad with the other types of vaccines they are given. So right now, COVID vaccine is off the shelf for pregnant women in India, but lactating mothers are getting it. Well, this is another very common thing that we are giving, that is the pregnancy nausea vomiting medication. Antacids, anti-vomiting drugs. What about them? Now, there is one drug that we give, that is doxinate, that is doxylamine and pyridoxine. Pyridoxine is vitamin B6. Now, the combination of doxylamine and pyridoxine is what is commonly known as doxinate. This is the drug of choice. This is a category B drug. The only side effect is drowsiness, but this has been studied over decades and found to be absolutely safe in pregnancy, and that is our first drug of choice, which can be taken throughout pregnancy for people who are suffering from nausea vomiting. Most of the time, the nausea vomiting is restricted to the first trimester, say up to 14 weeks of gestation, after which we start the iron, calcium, and the other protein supplements. First 3 months, what we generally give is a folate B12 supplement along with this doxylamine. So these are safe drugs in pregnancy. The other drug, that is ondansetron. Now, this is earlier, it was found that there were studies that showed that this could increase the risk of some facial defects or a heart defect. But this defect risk was less than 0.5%, which is again lower than the 3% birth defect risk. And so therefore, after say 8 weeks, it was considered that you can give Ondem to relieve pregnancy vomiting. What about the proton pump inhibitors like Omes, pantoprazole, that is PANDI? Now, this is also considered category B now, that is, it is safe to use in pregnancy, and that is why sometimes even we prescribe it with every antibiotic course, or sometimes even when the patient starts iron therapy, iron tablets, and iron can cause a great amount of gastritis and discomfort, and it is not tolerable. So for the first 10 days of iron, once iron is started at 14 weeks, we can even co-prescribe pantoprazole in order to help any acid peptic disease or the GERD, that is the gastroesophageal reflux disease, where there is a lot of heartburn. So people who have already been taking antacids, we tell them to use it with caution, but at least the good news is that it is a category B drug now and it can be taken. Now, there are some other things like Digene gel, Mucain gel, which contain calcium carbonate, aluminum hydroxide, the antacids to neutralize the acid. These are also safe. Now, take all this with a little pinch of salt. Do not over indulge, and but consider that they are safe in pregnancy and lactation. They do not have any harm to the baby. What about Dufalac, that is lactulose, which is prescribed for constipation? That is also category B, so it is safe. So basically the bottom line is that whatever drugs we are prescribing from our side, we generally prescribe category A or category B drugs. Whenever there is a doubt in our mind whether some drug should be used or not, we take a call to not use it rather than use it unless there is a very pressing need, and unless the patient has some disease which needs to be treated and needs to be some category C or D drug needs to be used in it. Now, where all this birth defect and drugs related birth defects, the story unfolded with when this tragedy occurred with thalidomide, which was an anti-vomiting drug in pregnancy, and thousands of women who took thalidomide, which is now a category X drug, they caused limb development defects, like babies were born without limbs or just limb buds. That was called phocomelia. So that was a typical thalidomide baby, and that was when they realized that actually it is this drug, anti-vomiting drug in pregnancy, that has caused all these birth defects. And then the whole concept of organogenesis and the insults during that time causing birth defects by our prescription drugs, that story unfolded, and then we became very careful. And then after that, all these studies started happening to get some kind of drug safety profile for all our drugs. Let us see another very common thing, that is radiation, X-rays or CT scans. Now, suddenly due to COVID, so many people took high resolution CT scan, HRCT of the chest, and some pregnant women were also exposed to such things. So, because again, COVID became a life-threatening disease, and therefore it was considered that the mother's life be given more due importance than the pregnancy, and certain investigations were carried out. So people do undergo X-rays, either with the knowledge that they are pregnant, which should not be done, or inadvertently when they're just, they think that they're going to get a period the next week, and then they miss the period. So then they come and say that we've had. So, people have had an accident, and then there's a fracture. Then they undergo X-rays of the limbs or extremities, head and neck, chest. And they want to know whether it is safe to carry on the pregnancy, because they suddenly find that it is, they have been they have had a radiation exposure. And so what is radiation? What is radiation? So there are two either they cause abortions, like if they are so strong or so harmful to the baby, then in the first 8 weeks of life it will just cause an abortion. There is no choice in the matter. But if it is not causing an abortion, then probably it doesn't do any defect, doesn't cause any birth defect either. But what happens is, what we are constantly being subjected to radiation. All right, let me talk about that later. Non-ionizing radiation like MRI. MRI can be done for the brain. Now, supposing a patient comes who has had an accident, road traffic accident with a concussion injury, and you want to do an MRI of the brain, it is perfectly safe to do MRI with or without contrast in a patient who is having convulsions or has epilepsy or any other reason to get an MRI. It is safe in pregnancy, but to be done with a little bit of caution. Of course, you cannot do repeat MRIs. 1 or 2 exposures is all right. So the whole thing about this was that when we are talking high dose radiation, we are talking about like Hiroshima, Nagasaki, or the Bhopal gas tragedy, where, the generations of babies got affected and they developed what is leukemia or blood cancer because of the radiation exposure in utero. We don't see that kind of like Chernobyl or Bhopal gas tragedy. Those are the things which can actually, that is when we mean high dose radiation. Okay, more than 20 rads, more than 50 rads of radiation. Then in between, because there was the IT spurt came, and more women, pregnant women, were spending a lot of time in front of the computer screens. And then if they had an abortion, then there was a risk, there was some kind of doubt whether this electromagnetic radiation from their computer screens or laptops was causing any kind of harm. Or it has been proved beyond doubt that any kind of electromagnetic sound waves, radio waves, microwaves, these do not cause any harm to the pregnancy. So your computer screens are safe, laptops are safe, microwaves are safe, mobile phones are safe. These do not cause any direct radiation exposure to the growing baby. So you can all be rest assured, because we are all living in a world where you cannot do away with these gadgets. The only thing is, what they said was, initially the concept of laptop was that it should be kept on the lap, on the thighs. Instead of that, of course, we can keep it on the table. We don't keep a heated device because it gets heated, and heat can cause defects. Heat can be harmful to the baby, even though this is very less heat. So any mobile phone or laptop or any device, you should not place it directly on your tummy while you're working on it, so that it is not in direct contact with your pregnancy. So that is what I would like to talk about, the radiation. Meanwhile, we are under constant, like, our ultraviolet radiation from the sun, sound waves and radio waves, they are all the time with us, and we are constantly exposed to some radiation or the other. But this is not the radiation that can cause a harm to the pregnancy. So the mobile towers, and there was a lot of thing about that radiation causing harm to the birds, but so far it has not caused any harm to the human beings. Ultrasound, that is ultrasonography, which is done at least 5 to 6 times in the course of a pregnancy, is extremely safe, because these are again sound waves, and sound waves are considered very safe. There is absolutely no harm to the baby. So don't worry about the number of ultrasounds that are given and whether there is any radiation. Radiation is coming only from CT scans and very high exposure, like radiation, like radiotherapy for cancers. Those are the kind of radiation that we are most worried about. Let's talk about another interesting thing that people do not consider a drug, but it is a recreational drug, that is alcohol. And there are people who drink alcohol regularly, but when they get pregnant, they have to cut it down. We tell them, please do not consume alcohol. Unfortunately, we don't take the alcohol history. We do not, when a patient comes to us, we just assume that she knows that she has to abstain from smoking and alcohol, and we do not take that history as per se. But it is so important to cut down, not just cut down, abstain from alcohol, because there is no safe time to have alcohol throughout pregnancy, especially in the first trimester. The reason being that whatever alcohol you are consuming will go as it is into the fetal circulation, and the baby does not have the liver capacity to metabolize that alcohol, and so the alcohol remains unmetabolized in the baby's body, and then it can cause a variety of defects, and there is no safe amount. I have patients who suddenly send me a message saying, can I have a glass of wine tomorrow? So I say yes, but then that is for that particular one day only, because even that time I don't expect the patient to binge. She just has to take one peg or one drink, and that is it. And then dilute it with enough water so that the baby does not get a very high concentration of blood level of alcohol. So more than 2 drinks a day, if a person is regularly having alcohol, she can have abortion. She can have what is called fetal alcohol syndrome, where there are a number of defects in the baby. There can be a premature delivery, there can be a low birth weight, and there can even be a stillbirth. So please do not use alcohol even for any recreation during the course of the pregnancy, even if it is just one glass of red wine or just one beer, try to avoid it, because in the interests of your baby, which cannot tell you what the alcohol is doing to it. Okay, so just be a little careful about that. Smoking, of course, passive or active smoking and nicotine can cause vasoconstriction and growth retardation in the baby. So we do not advise that at all. We should abstain. Now, when we say abstain, that is sounds like pontification, but we are trying to say that in the best of your interest. There is no safety thing like, can I have just one drink or can I have just one smoke? We feel bad telling you absolutely no, but then do it at your own risk. If you must have recreational drugs, do it at your own risk. The doctor is not going to give you any flat or blanket permission to use any of these things. So and there are so many other things which I have possibly not covered, but these are some of the things that we regularly face questions about. The other thing is OC pills, like the oral contraceptive pills. So sometimes, because of some reasons, you want to postpone a period and you take registron or primolutin, which is not ethisterone, which is just a progesterone, for to delay the period or prepone the period, and then find out that you're pregnant. These have been proved to be category B. These do not cause any birth defects, so don't worry about that. You can definitely continue the pregnancy if you want to continue the pregnancy. The choice is yours. We do not ask for termination of the pregnancy. As I said, the only things that we definitely terminate a pregnancy for are the category X drugs, and that is vitamin A, that is misoprostol, which is the abortion pill, and certain things like ergot alkaloids, or some drugs which can cause uterine muscle stimulation and abortions. So those are the drugs. And of course, some drugs which are typical no blanket ban in pregnancy. If you're already on those drugs, we try to shift you over to a safer alternative. Thank you so much for giving me a very patient hearing. If there are any questions, I will take it. So there is a question whether you can take beta HCG injection for a rupture of the follicle without follicle monitoring, because there is no scope. There's a patient who wants to conceive, and she has been told by the gynac to anyway take a beta HCG on day 11 of the cycle. There is no harm as such, but the only problem is that if you take beta HCG prematurely, when the follicle has not come to the size of rupture, which is 20 millimeters, then it can cause a premature rupture of the follicle with a smaller, and then the egg which is released is not mature enough to actually fertilize, which is why we generally try to give beta HCG with follicular monitoring at the optimum follicular size of 18 to 20 millimeters. There is no harm as such, but then don't expect a pregnancy. If it doesn't happen, then at least you tried, because frankly you are not in a condition to choose if there is no facility for ovulation monitoring. But what you can still go with that. But I would suggest you take it possibly not on 11th day, but maybe on the 14th day of the cycle. 11th day would be a little premature, because even with ovulation inducing drugs, what we have seen is that the follicular size comes to optimum only after the 13th, 14th, 15th day. So in a natural cycle of a 28-day cycle, we see that the ovulation has taken place on the 14th day. So I would suggest that if you do need to take HCG, take it not on the 11th day, but maybe on the 14th day of the cycle, so that you might have a little percentage chance to conceive and then have timed intercourse during that particular period. There is another question about Tidilan retard. So Tidilan and Duadilan retard, these are isoxaprine, and these have been used over a period of decades for uterine relaxation. For premature labor pains. Now, what has happened is in the last, say, 5 years, there have been studies to show that even though there is a certain degree of safety for use of these drugs, beyond 10 days, these drugs actually do not work because the receptors in the myometrium, that is, receptors in the uterus, actually just get saturated, or they get tachyphylaxis, they stop reacting to it. So, and in certain conditions where the mother has a heart defect and all, these drugs can actually be harmful to the mother. We are giving Tidilan, Duadilan retard only to push the pregnancy a little bit further so that the baby becomes mature in case of premature labor pains. But in the last 5-6 years, it has been proved that progesterone, there are safer alternatives. Progesterone hormone in the form of either micronized progesterone oral tablets or vaginal pessaries, and injectables like injection maintain or injection proluton depot. These are safer because progesterone is a better uterine relaxant. And if anything else needs to be given, then there is another drug called nifedipine, that is Depin retard, which is a calcium channel blocker. That is a safer option than Tidilan retard to actually give, and it gives a better, and it can be continued for a longer period of time because it will just give rise to a little lowering of the blood pressure. Even Duadilan or Tidilan will give rise to low, because it's a vasodilator drug, will give rise to a little lowering blood pressure, but that is safe in pregnancy. Vasodilatation, that is increased in the caliber of the blood vessels, will actually push more blood into the baby. So Depin retard, I would personally say, is a much more effective form of what we call a tocolytic, that is the drug which is used to relax the uterus. So you might want to consider it and discuss it with your obstetrician. But yes, we have used Duadilan retard to death actually in the last decade or two. We have even given Duadilan drips in order to immediately bring about a uterine relaxation, especially when we do procedures such as cervical encerclage or os tightening, when we put a stitch in the cervix, when the cervix is short. Then that time we have used at least 5-6 days of Duadilan retard to keep the uterus quiet. But then beyond 10 days, it actually stops having effect. So it becomes more or less a redundant prescription. So you just want to, continue it with some other kind of tocolytic. And of course, progesterones throughout pregnancy are now rampantly prescribed and they are safe. So rather than taking Tidilan, it's better that you take some form of progesterone, some form of, even injection progesterone every 15 to 20 days. That is also a very good option. And it is safer also. I think we'll call it a day. Thank you so much for being patient listeners, and thank you for the questions. And let's meet up if you have any other doubts. Thank you so much. Have a nice day. Pas lagi